Hello, everyone. Today, Dr. Jennifer Lynde, trauma fellow here at Ryder Trauma Center in Miami, will present a case. Dr. Lynde.
Hello, everyone. As Valeria said, I'm a fellow here, finishing up this month, actually, and then I'll be going active duty with the Air Force to UC Davis in California. But I wanted to discuss a difficult case that we've had, and then in general, some things about pediatric gunshot injuries. I have nothing to disclose. The objectives are quite general. We'll talk about the injury mechanism and risk factors for this particular patient, some diagnostic and treatment interventions that we did, and then analyze strengths and weaknesses and the outcome. And then in addition, I'll talk a little bit in general about pediatric gunshot injuries and things to keep in mind as a practitioner treating these patients. So first is the case study. We had a 15-year-old female BC who was brought in to our trauma bay, carried by her family member. They were running in quite anxiously. The girl was shot in the right lower quadrant from the abdomen and had unclear circumstances exactly as to how and why she was shot. On exam, she had an intact airway with bilateral breath sounds. Her vital signs showed that she was in shock with a heart rate to 120 and a blood pressure of 90, and she was diaphoretic, and she had no IV access because she was brought in via her family. Her GCS was 15. We were able to get an IV quickly and also send a type and screen. So while they were doing that on her exam, she had one aperture to the right lower quadrant, nothing else on the back, perineum, rectum, legs, nothing else. So she did have peritonitis. I'm sorry, can someone mute their mic, please? I'm getting some feedback. She did have some peritonitis on exam. She did have bilateral palpable distal pulses, as well as an intact motor and sensory exam in both legs. So this patient belongs in the OR, certainly. There are some things that, some differences in practices, and this is a time when I would open it up to some question. So you know you're going to the OR, but is there anything else you might want to do prior to going to the OR?
Dr. Rahman, would you like to make a comment?
No, usually we will get just a plain film in the OR to get an idea where the bullet might be located, but it's not necessary. We just do it because it's super fast and super easy, but this patient needs to go to the operating room. Thank
yes,
you.
It's not so fast and easy everywhere to do that in the OR. So,
thank you, Dr. Rahman. Dr. Antrak, any comment? Cannot hear you, doctor.
Yes, I agree with what Dr. Hockman said, but 2 intravenous cannulae, and needs a little bit of fluid to set up some blood, and probably she has significant blood loss for those parameters, about 1/3 to 1/2 her blood volume. So I, put in some cannulae, take a sample of blood for the lab, and then give her 1 or 2 units of PAC cells to see if she if she responds or just a transient responder, because that'll give some prognostic information, and then at that point proceed directly to the operating room. Foley catheter, all those things that you would normally do, and then straight to the operating room.
Thank you, Dr. Antrak. Dr. Colette, would you like to make any comment?
No, I agree with all comments. I think the patient need to go to the OR quickly.
Thank you. Anyone else? Any additional comment? Dr. Lynde?
thank you. So we didn't do these things, but these are things I thought of in hindsight, given that it was a a lower abdominal injury, maybe a digital rectal exam, although that can be traumatizing, especially for pediatric patients. The type and screen, which we did grab, and then we called blood bank, given that she's a 15-year-old female. You know, they really wanted to give typed cross blood. I think she did end up getting some uncrossed though in the OR. We didn't wait for blood in the trauma bay. And then other things to consider would be the x-rays, but again, not necessary or not required. So in the operating room, this is not a picture of her. This is just, and I don't think that's even an aperture, but this is about where the wound was on the right lower quadrant. There was no bleeding from the injury, but we were holding pressure in the trauma bay and then in the OR to make sure that if there was something, it wouldn't start exsanguinating more. After laparotomy, there was hemoperitoneum with bleeding in the pelvis. We packed everything and then looked all around systematically. The bullet seemed to have tracked from right to left, entering the left pelvic sidewall, and it missed the iliac vessels, common, external, internal, right and left. Everything was spared. The ureter was also spared. She was quite lucky. The only thing that wasn't spared was her small bowel. It was actually peppered quite frequently. So the ileocecal junction was destroyed, frankly open. And then she had several small bowel enterotomies from the ileum to mid-jejunum. So after making sure there was good hemostasis, we had resected all of those injuries, which ended up being 2 small bowel resections plus the ileocecectomy. And then we put a lap pad or 2 in the pelvis to where that injury was, where the bullet had entered the left pelvis, to tamponade the area a little bit, and then placed a temporary abdominal closure. So post-operatively, she got a significant amount of product, 6 of red cells, 8 of FFP, 1 of platelets, and 1 of cryo. And of note, she weighed about 32 kilos. She was quite a small or thin person. We sent her to our pediatric intensive care unit and she was intubated. They kept her intubated for the next 48 hours because that was a little bit easier than waking her up and extubating her and then reintubating her for second look laparotomy. So we took her 48 hours later for her washout. Everything looked pretty good. There were a couple edges of the small bowel resections that were ischemic, but the rest of the bowel, including the colon, looked healthy. There was no bleeding that we noted. So we went ahead and resected those ischemic edges, which were just at the staple lines of our prior resection sites, and then did 2 stapled small bowel anastomoses, and then 1 hand-sewn ileocolonic. And then at that point, everything looked great, washed it out and closed the abdomen. We left her skin and subcutaneous tissue open. So post-operatively, she did well. She got extubated. There were some, psychosocial issues happening. She had come from, her parents did not live together, and she was recently brought to Miami from Chicago, where her mother lived, and it wasn't safe. And then she came here, and then this happened here with her father. So things were a little bit, her parents were very cordial, but it's just not a great family situation that she was in either location. We kept her in the pediatric intensive care unit. Post-operatively, things were getting better. However, her leukocytosis that was improving then suddenly got worse, going from 14 all the way to 27, which is not what it had been before. It was in the low teens. So that was quite a jump for her. There was no sign that her wound had any sort of breakdown or anything. We did get a CT abdomen pelvis that showed some interloop fluid collections, but nothing that was amenable to percutaneous drainage. And she, the next day, had nausea and emesis, and then on exam again of her wound, she actually had some fascial dehiscence. So at this point, we took her to the OR for another laparotomy because there's obviously something happening given the fluid collections and now a dehiscence. We felt it right to return to the OR. So on repeat laparotomy, she had stool as well as breakdown of her ileocolonic anastomosis, which was hand-sewn with active leak of succus. And then she had remaining healthy bowel, no other concerns except for those fluid collections between the loops. So that was all washed out. We resected the anastomosis and then gave her an end ileostomy and closed the fascia. So now this 15-year-old who had a gunshot wound and multiple bowel resections with 3 anastomoses, had 1 leak, and now has an end ileostomy and 3 laparotomies. So in hindsight, of course, it's 2020. I think anastomosis at the time of surgery is probably not a good idea, given that she was in shock and she required a significant amount of blood products. And the stapled versus hand-sewn anastomosis, I would leave that up for discussion in the group. I know there are big opinions about these things.
Thank you, Dr. Lynde. Dr. Antrak, would you like to make a comment?
Sorry, I keep forgetting to unmute. Yes, in this case, I think it's, the anastomoses were done at the second laparotomy. So at that point, she wasn't in shock. It was 48 hours later. And I don't know how long she was in shock even during the first laparotomy. So, I think it probably should have been okay. Your small bowel anastomosis worked, and an ileocolic anastomosis is almost like a small bowel anastomosis. So you were there, so you might have some idea why it broke down after 9 days, so a little over a week. And it's either a technical error with a stitch that or there may have been some distal obstruction, or you might be able to, you'd have a better sense of that. But I think it's okay to do the anastomosis. I probably would have done the same thing. And, I was raised hand sewing, so I might use staples if I have a lot of anastomoses. I want to go a little faster, but, they should be equivalent. And the only other thing I would have done differently in this case is I would have done a partial anastomosis, an ileocolic anastomosis, and then brought out basically a double barrel stoma, simply to avoid having to do a full laparotomy a fourth time now. When she comes back with adhesions, and it'd just be, when she's all better, a lot easier to close, just a local operation with avoiding going back in and potentially more enterotomies, whatever. But I think you did fine. You just have to replay in your mind what, if you think it might have been a technical error. I've had anastomoses leak, and I can sometimes, say, yeah, that's why it leaked. Something that I did technically, I should have done differently. But in terms of the strategy and your management, I can't really fault anything you did here.
Thank you, Dr. Antrak. Dr. Ochman, would you like to make any comment?
No, I agree completely with Dr. Antrak. I would have done exactly the same way. And sometimes anastomosis leak. There is no way. I like the idea of bringing the double barrel to simplify the closure in the future. But this happens.
Thank you, Dr. Ochman. Dr. Resende Neto, would you like to make any comment?
Thank you very much, Valeria. So my question is, the ileocolic anastomosis was done on the ascending colon or on the transverse colon?
I believe it was ascending.
Yeah, so that's something that we always have these problems. And I don't know, I always prefer, if the ascending colon is, even if it's undamaged, but if you have a severe injury to the ileocecal valve, I take the entire ascending colon and I anastomose on the transverse colon. And I've had pretty good luck with that. And every time I try to preserve the ascending colon, the chances, I always find that the chances of some type of complication is higher. I think that the transverse colon is better perfused than the ascending colon. So I go right beyond the hepatic flexure, staple that off, and then I bring an end to side anastomosis right on the tinea of the transverse colon. And I've had pretty good results that way. Hand sewn has Dr. Untrack said, I always do it hands-on. I was raised like that as well. But I eliminate the ascending colon. The ascending colon is a pretty unforgiving area. If to do anastomosis there, I always find it's a bit harder. And I do an end to side on the tinea on the transverse colon. Thank you.
Thank you, Dr. Ned. Dr. Colette, would you like to make any comment?
Yes. I think the great problem when make anastomosis in injury patient and patients with shock and who receive too much blood components. Sometimes you have the dissensions, and sometimes this can be prevented if you can put ileostomy in the first time. So sometimes when I thought my teachers, old teachers, in these situations, they prefer they put a ileostomy instead of big anastomosis. Sometimes I make anastomosis more frequently, and there is no problem usually. Can make an ascendant or descendant or transverse column. I think the great problem is to check if the ball is viable. So there is blending of the column, there is blending of the ilio, and then you can make safe anastomosis. If you use staplet or manual anastomosis, I think today there is no too much difference using stapler or manual anastomosis. I prefer sometimes using stapler anastomosis. So it's much easy and very safe. But I think these senses can be seen in any anastomosis. And so the great problem is can be avoided to be delayed to diagnose the anastomosis, the essence of the anastomosis. So I think the great problem is how to find early the signs of the essence of anastomosis. So that's it.
Thank you, Dr. Colette. I see there is a question from Dr. Juanita George from Antigua. Dr. George.
Thank you. I'm sorry I couldn't participate at the beginning. I just wanted to make some comments about this patient. I think this was a very small frail. I think she said 15-year-old. And, you know, we do, as general surgeons here, we do a lot of pediatric surgery too. And for most of our pediatric surgeons, in a patient like this with multiple small bowel injuries and this peritonitis in shock, the initial procedure, I would have resected from where the injury is in the terminal ileum and the entire right colon, and brought out the ileostomy and a mucus fistula of the transverse colon without doing any anastomosis in this initial surgery. And then in the second look, then I would really go in and do this iliotransverse anastomosis and then a loop ileostomy to protect that suture. I think that might have been a better option. And we do most of our pediatric anastomosis are hand-sewn. I was trained doing, hand-sewn anastomosis years and years ago, and we continue to do our pediatrics patients by hand versus staple. But I think any surgeon could have had a leak in a case like this. Thank you.
Thank you, Dr. George. Anyone else? Any additional comment?
Yes, I just wanted to ask whether the anastomosis I thought were done at the second operation, weren't they? The resection at the first and then the anastomosis at the second?
Correct.
Right. So I guess in this case, Dr. George, you would have done the resection at the first operation and then brought the ileum and the colon, but so you would have resected all of the, if you could have gotten all of the bowel, the enterotomies resected as one segment, you would have done that and then just bring the two ends out?
Right, yes. Yes, and this frail, if it's a frail, small-bodied child, That's what most of our pediatric surgeons, when we recommend, will do.
All right.
Thank you. Dr. Lynde?
It's interesting. And another vote for ascending colon resection. 2 days between the first two surgeries, 48 hours and some change. Okay. So postoperatively, she got better with the ostomy. Her family was there all the time, so we were able to give them good ostomy education, or at least so we thought. And the patient felt more comfortable with her ostomy. She did much better. She was eating. We given her weight, definitely having the ileostomy, and a person who's already quite thin prior to injury. We knew she's high risk for high ileostomy losses, in addition to malnutrition and weight loss. So we educated her and her family on making sure she had enough to eat as well. She was discharged home, but then eventually presented 2 days later with nausea and emesis, not necessarily because of the ileostomy, but the mother, who is Spanish speaking only, and the father is, and with a lower literacy level, had a lot of difficulty trying to figure out the ostomy and how to pouch, how to care for it, how to measure the output, in addition to get the daughter nutrition, because she had a lot of emesis and she had some small fluid collections in her abdomen. So she got readmitted to the hospital. And she underwent percutaneous drainage of one of the fluid collections, but it was quite small. And she was started on TPN. She was started on TPN after her injury, like that night. We ordered the TPN for her to be started the next day because she came in around 8 p.m. So that was too late for the pharmacist to make it and get it hung. But nutrition has always been on the forefront of our minds with her in particular. And now there's some added issues with home care. Can she have home care? And I know, based on different insurance policies, at least in the US, and based on different home care agencies, certain home health care agencies won't visit a certain area or certain patients that are injured in a certain way, such as gunshot wounds, stab wounds, because it may put that home health care employee at risk as well. So that could have been a lot of the problem there with her first discharge, and in addition to her having an abscess that needed to be drained. So she's been admitted again and is being treated for the abscesses and really undergoing nutritional optimization with TPN, because she didn't like the small nasoduodenal feeding tube. So we're doing TPN for now. And then she's also getting daily weights to make sure that she doesn't lose. And she is eating more now that she's being treated appropriately for the abscesses. I'm just going to check a question. Oh, that's Valeria. So of a complicated patient, you can see that, it just started with one gunshot wound and some bowel resection. Wasn't a lot of vascular injuries or any vascular injuries, but for this patient, it has now rippling effects that will affect her for the rest of her life, in addition to her family. And it's going to be an ongoing thing. I'm going to transition a little bit and talk about pediatrics and gun violence. Most of the stuff will be out of the US, or at least what research there is. This is firearm-related injuries, our second leading cause of injury-related deaths in children and adolescents in the US, with 38% being suicide, which I thought was high, and then 53% homicide, and then also unintentional as well, is in between the two. A lot of youth are exposed to either other people's firearm injuries, whether it's a friend, a family member, someone they know in their neighborhood, but 5% have directly witnessed a shooting, and that's in the last year. So things are going up and it's not just because of mass shootings, it's also because of the day-to-day violence between people that is also exposing more youth to firearm injuries. And then people that do have these firearm injuries, youth that have these firearm injuries, like our young girl, which affects their education, and affects their health outcomes. And then overall, firearm mortality is decreasing in the US. We do a lot better at saving these children, but especially younger children, they experience longer ICU stays usually and require more PICU care. And then at that point, they're also at risk for more long-term sequelae, not only from the injury itself, but also from critical illness and everything that comes with that, whether it's prolonged intubation, ICU neuropathy, deconditioning, etc. Gun violence is considered a problem to different people. It is based on different things. So whether you live in rural Kansas or if you live in the in Chicago, different people will think that gun violence is actually a problem. Typically, people that are in rural areas are for more gun expansion and appreciate having their guns, whereas people in urban areas will say that gun violence is a problem. The race matters too. Black people here in the US at least would consider that gun violence is a problem, whereas less white people would. And Hispanic was 58%, and white people or Caucasians were 39%, considering it an actual problem. It also depends if you are not only political parties, but socioeconomic status as well. If you are more affluent, it's unlikely that you're going to consider gun violence to be a problem. So it just depends on your point of view. For children especially, long-lasting effects are not only physical from the injuries that they sustain, but also mental and social. So not only do the children have functional limitations potentially from their injuries, but they can also have headaches due to chronic stress, which include migraines. They can have deteriorating physical health or death in their loved ones, like their parents. Also can have deteriorating health because they have to take care of the child, and it's very taxing on themselves. Or if the child dies, then the parent can also become ill that way. The children also can have impaired immunity from chronic stress, chronic pain. Patients that are, especially children or youth that are shot, have higher incidence of chronic pain in the future, substance abuse, and also mental issues, which I'm going to get into. And also traumatic brain injury can be one of those long-lasting effects. Post-traumatic stress disorder is especially high in children or youth after being shot. Not only children, but adults also have this at a higher frequency after firearm injuries. Substance abuse, anxiety, depression, suicidal thoughts, complicated grief. That is where you have grief, but it is prolonged and it is unwavering and just basically like something you can't get rid of. It's is what complicated grief is. And then also survivor's guilt, not only from a mass shooting, but from day-to-day violence that people see. Maybe they were with their friend got shot, and the child or the youth could have thought that maybe that should have been me, I should have been the one that died, things like that. And then also when youth experience this on a daily, weekly, monthly basis, they can get desensitized to violence and just think this is a way of life. And my brother got shot, my uncle got shot, my mom got shot, and it can just be this recurring theme in their lives. I can't tell you how many people I've had that know what a colostomy bag is because 2 people in their family have it because they got shot. So it's something that they can eventually be desensitized to and just think that it's part of life and that's normal. And then socially, youth that have or are exposed to firearm injuries have higher recurrent risk for getting hurt by a firearm in the future. It can also threaten their beliefs about safety, thinking that they're not safe and that they're at a heightened level of alertness all the time because they could be shot at any time, which can contribute to chronic stress and impaired immunity. Youth that are involved in firearm injuries also are more likely to be perpetrators of crimes in the future or be imprisoned. Again, that cycle of violence. Their lower educational attainment. They don't graduate high school maybe. They don't get to go to college because of all of the social stuff, plus maybe financial hardship. They can't afford to go to college because they had all these medical bills or because they lost a parent to gun violence, and so they have to raise themselves and grow up a lot quicker. And they're also less likely to reach life milestones like getting married or buying a house or things that are socially considered normal. All of this stuff can be affected. And especially in the patients that we just spoke about, she's 15, she's got now an ostomy. Her parents, have to take time off to be in the hospital with her and help her work, or they have to work and not be there with her so that they can make money, so that they can pay for her stay and pay for her siblings. It's going to be this very long road for her and her family. And I think it's something that we don't think about all the time. So as surgeons, obviously we can deal with the initial injuries and the sequelae that come from that, whether it be an anastomotic leak, abscess, etc. But we can also help, like when we see these patients and follow up with screening for violence exposure. And then when that happens, we can also help intervene with the family and make sure that the parents are engaged to reduce long-term sequelae for the children, especially this family. I think there's been some discussion that she was maybe with her brother when this happened, when the initial injury happened. So maybe he needs to be involved with this as well to make sure that we create the safest home life possible for her, given that she had issues with home life with her mom in Chicago and now here in Miami with her father and brother. So we can do more by engaging the family to identify things and also help them with the help of social workers and home health care agencies, our adolescent physician colleagues, our psychiatry colleagues. And we can also help the family part by helping parents too, because the parents they may not have been injured, they can still have PTSD from having this happen to one of their children and having especially a child who has a prolonged hospitalization due to complications of the injury. So that can also, if the parent is having a hard time mentally, we can't expect them to take care of their child as well, who's also potentially having a hard time mentally and physically. So helping the parents get help to take care of themselves so they can take care of the injured child is very important to identify and treat. And then really, the violence prevention starts at the community level, and this has been obviously a hot topic, but starting in early childhood and continuing through adulthood is the most important thing. With recent funding of gun research, hopefully we can do more to look at the methods that we're currently using, evaluate them critically, and figure out if they're actually working. But we need to raise emotionally healthy children that grow into emotionally healthy adolescents and adults. And then when there are people who show signs of violence, we can try to identify them and intervene soon so that this doesn't happen, so that there isn't a school shooting or that there isn't more violence on the streets every day. And then this also involves different police training, mental health revamping, especially here in the US, social work assistance, and public health change, in addition to government policy as well. So in conclusion, I'll have time for questions and discussion because a lot of this was, data that I could pull from here, but there are many people here from other countries who can also weigh in on their experience, not only with pediatric gun violence, but violence in general. But this is a preventable public health issue, and it is increasingly more pervasive. And now youth are affected in all these different ways, and that can create a cycle that continues throughout their lives and can keep moving through the family. We need more research. We're quite behind on research about gun violence and injuries and what happens afterwards. Suicide-related injuries as well need research. I think the problem is that they're 85% lethal, so it's hard to get information on why, or got information on suicide-related injuries in general. And then we also need research about prevention strategies and is anything that we're doing actually working? A lot of research currently focuses on mass shootings instead of day-to-day violence that we see in the streets or in our trauma bays. And then reducing violence ultimately is a multi-system approach, and that involves a lot of different moving parts, but a lot of necessary parts. It's not all government, it's not all public safety, and it's not all healthcare. It is truly a process that has to involve everybody and start from the ground and work up. But unfortunately, primary prevention is key and obviously most effective at preventing the violence. So if we can at least help intervene when we have children that are involved, maybe we can help prevent future firearm injuries and the cycle that we've discussed here. I'm happy to take questions and we can discuss things further.
Thank you, Dr. Lynde. Dr. Neto, would you like to make any comments?